Are we all ready? Is everybody here? Has that been 5 minutes? Let's see what we got. All of these patients are real. All these patients I've dealt with personally, myself, in the emergency department. Lab work, I didn't make these cases up looking at their chart, but the lab work is going to get you to the right place. But if you're trying to do some special calculations and all sorts of, crazy stuff, which you probably won't, but if you do, just know that the figures may not, come out appropriately. If that makes sense, because the labs were just kind of off the top of my head. But they're not going to be, they're going to get you where you need to go. But just saying that the labs that I have here were just kind of generated as I was writing up the tech question. They weren't physically from a real person, so there's some irregularities that you can have through there. Okay. Okay. Man, chalkboard, old school. All right. Case 1. So, 26-year-old female presents with a chief complaint of right-sided abdominal pain for the past 3 days, and it has been worsening. So we're going to work through this case together, and all right. Let's develop our differential diagnosis, because this is exactly how I work, and this is exactly how I think you need to work. Before I even walk into the room, I read that chief complaint on the computer or wherever. Immediately, my head is filled with everything that it could be. And for me, just because I work in the emergency department, and I'm a bit of a worst case scenario, negative thinker type person, mine go immediately to what's the most deadly things. But we'll go most common, most deadly. But even before I walk into the room and even see a person, I see their chief complaint, I immediately generate a list of possible things that could be wrong with this person. So let's start with our list. Now, it's not going to be all inclusive yet because we don't have any other data. We have one sentence. We have a 26-year-old female with right-sided abdominal pain for 3 days. It's been worsening. Let's go. Give me some list. It doesn't, either one, either side. Say it again. Appendicitis. We'll probably put that right here. Under most deadly. Coli.
Ectopic pregnancy.
Ectopic.
Ovarian.
PID. Cyst.
Kidney stone.
Stone.
Torsed ovary. IBS.
Torsed ovary. Where should that be?
Deadly to the future, maybe.
Why most deadly? Are you going to die from a torsed ovary?
Become the
Well, your
cattle.
ovary will, yeah. So that's most deadly debility. I mean, you could possibly die if it gets, if it's septic and you get sick and stuff like that. But it's a debilitating disease to which there's no coming back from. So we'll put that under most deadly / debilitating.
Volvulus?
Volvulus.
IBS.
IBS.
Hernia.
Hernia. Where it's like, sure,
Common.
hernia.
Something common.
Okay. We good with that so far? Okay. Presentation. So pain is constant. It seems to get worse sometimes. She has some nausea, but no vomiting, diarrhea, or constipation. She has some vaginal spotting, but thinks that's just her period. No painful urination. She dies. Any fever, chills, recent illness, no other complaints or symptoms. No significant past medical history, surgical history, or family history. We want to add anything to this list here based on our presentation?
Pregnancy.
Pregnancy. Okay.
What about
Just weird periods.
She's on her period.
Yeah.
Yeah.
So,
Dysmenorrhea.
not pregnant?
Dysmenorrhea.
Dysmenorrhea, okay. My handwriting is beautiful. I don't want anybody to make fun of it. Okay, Exam findings or vital signs are as shows. Heart rate 104, BP looks good, everything else looks fine. Right lower quadrant tenderness, mild to moderate, no rebound or guarding, normal bowel sounds, no masses, everything else is normal. Other than the fact that her heart rate's just a tad tachycardic. Epidemiology, so probably not going to help us much here. We have a 26-year-old female with abdominal pain. Could be about a billion different things. We could probably write the entire chalkboard full of possibilities. Okay, based on her presentation, vital signs, and physical exam, now do we want to add and or remove anything? Because our differential diagnosis is a complete list of things that we have, but we use history, presentation, epidemiology to add and remove things. So anything based on what we've given here, do we want to take off? Do what? Okay. I probably wouldn't. I probably wouldn't do that.
Are you gonna put special tests in there? Would you have included the special test findings? Like McBurney's point?
Oh, sure. She's got McBurney's, Rothstein's, heel jar, obturator. She's got them all.
Okay, we'll keep them then.
When we rotate, well, I'll tell you my real opinion on all that junk. But for this, that's all great. She has no rebound tenderness.
I think it on there though.
I think he's saying that.
She has no. So she has peritoneal signs, but no rebound tenderness. Take that. This is a real person. She can have whatever she wants. Do what? Volvulus? We want to take that off?
Yeah.
Okay. Sure. Normal bowel sounds. No vomiting. She's never had any surgeries. Likely IBS. So she doesn't have any diarrhea or vomiting. Probably not IBS. I mean, you can't have an IBS constipation type, but we'll say she has no constipation. Hernia. Okay. We didn't feel any hernias. Any obvious hernia on our exam?
She had CVA tenderness.
No CVA tenderness.
Take off the,
Take out what?
maybe the stone. She didn't have,
Oh, that's all.
she didn't have painful urination either.
So, what did I say at the very beginning of this lecture? When we were talking about, I'm not yelling at you because I'm angry. I'm like trying to make a point. I feel like I'm like the type of person whenever somebody gets onto me, it drives it home. So I'm going to treat you all like that, even though I'm sure it's not the case. What did I say when I first came in here and started talking about a puzzle?
A single lab kidney.
That it's all a piece of a puzzle, and about how all of you guys are gonna key in on one thing and make that your whole world. So she doesn't have a kidney stone because she doesn't have CVA tenderness. What if she has 100 red blood cells in her urine and it's more, right lower quadrant pain? She can totally have a kidney stone. But you saw that one thing and you keyed in on it and you're just like, oh no, not a kidney stone because she doesn't have CVA tenderness. That's a mistake that everybody makes, but as I'm trying to teach you, don't fall into that. But we'll cross off anyways, because whatever.
Would she have painful urination though? Because you said it wasn't painful. If she had a kidney stone, could she still have pain-free urination? Okay.
She's a real person. She can have whatever she wants. And these are meant to be vague. I do that intentionally to kind of help you guys work through this. If I gave you a textbook, spoon-fed case of a kidney stone, there's no point in asking that. That doesn't help you work through anything. So these are intentionally vague, just FYI. Okay, so, we got a pretty good list here. For abdominal pain, let's see if there's anything that we missed. I think that looks good, Okay, so labs, what do we want to order?
Pregnancy test.
Okay. All right. Good, you guys are all doing good. I'll tell you the way that I do labs, and this is just me personally. I think it's easier to divide them up into 3 separate kind of categories and work your way down. I think it's easy if you just start throwing like this and that and this and that. It's easy to kind of miss things. So I typically start with blood, like diagnostic tests, so blood work. And that includes urine, okay, blood and urine. Special tests, So that's gonna be like an LP or an EKG or some kind of special thing that you're not gonna do often. Radiology, so any kind of radiological exams that you wanna order. And then after that, I do treatment. So for that sake, let's start off with the labs that we wanna remove, and let's start off with blood in urine. What do we wanna order? CBC,
Pregnancy test.
CMP.
urine preg,
Regular UA.
sure, CMP. We'll say lipase, because I don't like amylase. How are you guys ordering those? Yeah, like what makes you think to do a CBC? Why are you doing it? Okay. Why are we doing a lipase? Is lipase significant for cholecystitis? And why are you guys ordering?
Yeah, it's not on our list.
It's not on your differential. So we order these labs to help us figure out this. So why are we ordering labs for something that's not on here? If you want to order a lipase, fine. Put pancreatitis on your differential and explain to me how a non-alcoholic 26-year-old has pancreatitis without vomiting and epigastric pain, but hey, it could happen. But we're not just plug and chug throwing these things out there. And I think that's where students get confused a lot on what to order. You know, I was like, all right, what do you want to do? And I'll get this blank stare. Think about your differential diagnosis that we took all that time doing, and then order tests to prove and disprove the things on here. Okay? All right. CBC, urine preg, UA, CMP, lipase. Anything else? Okay. Here are the results. Do you guys know what I'm drawing up here? We will.
Years ago.
Back in January.
Should we do the quant assay? Or whatever? Yeah.
I think maybe it's positive for you.
Okay. So this is for your CBC. Hemoglobin, hematocrit, white blood cell count, platelets. Okay. Sodium, potassium, chloride, bicarb, BUN, creatinine, glucose. And these are the results. Okay. What do you guys think? Urine, sorry, so we'll go over them quickly. So, you got 12.6 white count, H&H stable, normal platelets. Her BNP here looks pretty normal to me. I don't see any abnormal findings. We did a CMP, so her hepatic enzymes are normal. Her urine, she's got 2+ leukoesterase, 10 to 15 white blood cells. No nitrites, spectgram and everything else is normal. Her POC, she has positive pregnancy. So, can we get a diagnosis here yet? What do you guys think that she has? An ectopic pregnancy.
Yeah.
Okay. What do we want to order?
Ultrasound.
Ultrasound. Okay. Anything else?
The serum pregnancy, the quant assay. Or
Serum quant. Anything else? ABORH.
RH factor.
Blood typing, basically. Anything else? Okay. Any treatments yet? Do we want to do anything for her? Nope. Okay,
How do you want your ultrasound?
sure.
So like if you're thinking of like threatened abortion versus ectopic pregnancy, like can you see them both by abdominal? Or do you have to do transvaginal?
I would do transvaginal.
Have the pelvic exam.
Have we done?
Yeah.
Exactly.
Yeah.
We haven't done the pelvic exam yet. You wanna do the pelvic
Is she
exam?
bleeding?
You what?
Body.
Alright,
Like true, like pelvic.
alright, so her pelvic exam is, she has a little bit of blood in her vaginal fornix, but her os is closed. Closed-ish. It's not dilated. It's not dilated. Her serum quant is 3,500. She is Rh negative blood. And the ultrasound shows a right ovarian mass. No IUP. So do we have a diagnosis? What is it? Ectopic pregnancy. Good. What do we want to do now? Call a general surgeon?
OB.
Call an OBGYN and tell them what? That you have a probable ectopic pregnancy. Okay. Disposition. Home, admission, or transfer. So you're working out at Mercy Logan ER and we don't have OBGYN.
Transfer.
Transfer. Okay, good.
What's IUP?
Intrauterine pregnancy. Yeah, sorry. If I use anything up here that you guys don't recognize, just ask me. These things just kind of flow out. All right.
Would you give her a even though you're gonna lose that?
Would you?
If she's gonna
Yeah,
deliver
why?
it vaginally.
Because it's so.
Because she's Rh negative, right? Does Rogam help this pregnancy?
The next
No.
one.
Excellent, excellent. A lot. You guys are probably the first class in there, however many years I've done this, that's actually ordered a Rh type on it. Good job. Anytime you have a pregnant woman who's bleeding. Did you guys have that yesterday?
McNeil nailed
Because it's
that.
total BS. You guys are the first ones that's ever got that. Every time I've given it, that's like the one thing they always forget to do. Most students will get to the ectopic. Yeah.
We talked about an OB.
Good, good.
It was just so fresh.
Excellent. Okay, all right. So the next one we're going to go through a little bit more quickly. That was just us kind of working through it. All right. 32-year-old female, low back pain. Pain is present in low back on both sides. She has a history of low back pain from an injury in the past, but she says this feels different. Denies any recent injury. Excuse me, she has no radiculopathy, denies the abdominal pain, dysuria, or frequency. No other complaints, no significant past medical history. Epidemiology, probably no help here. She has tenderness palpation in the lower lumbar paraspinal muscles. No saddle paresthesia, no bladder tone loss. Otherwise, no normal. Yep. Vital sign stable, VSS, vital sign stable. Okay. Differential, what are we doing? Oh, sure. We'll put that right over there in the That's what I need to do. I need to start keeping a zebra list. I'm glad you said that. You guys come up with some weird stuff, man. This is an ER.
Herniated disc?
Yeah, that's what I was gonna say.
Herniated disc.
Compression fracture?
Muscle strain. Sacroiliitis.
Bilateral.
What was that one?
Sacroiliitis.
Did you hear compression fracture?
Yeah.
Compression
Compression
fracture. She was walking around as a healthy 32-year-old has a spontaneous compression fracture.
She said she's had
Spontaneous
back
compression
pain.
fracture, no trauma, but it happens. Sure. Yeah, that's it. Right. She has a spontaneous fracture. Could happen. Anything else?
Yeah, hang on.
Yeah, hurts on both sides.
Yeah, no, we have zero mechanism.
No, she doesn't like talking.
Doesn't work out.
She's actually kind of pissed that she's here. She wants you to hurry up.
Kidney stuff.
Kidney stone, okay.
Kidney infection.
Pilo's right.
Philo, okay. Needs to be on there. No fever, no tachycardia, but,
Has she gained weight?
no.
Okay. That's the first thing I think of when people complain about their back.
Sure, too fat, lose some few pounds. I wouldn't say that. Anything else? Okay, what labs you want to draw?
Pregnancy.
Okay, oh, yeah.
Pelvis.
You're in preg, man. Okay, good. Why do we do that?
Because she's 30-year-old.
Yes, everybody who has a uterus that's between 9 and 60-ish, 50, late 50-ish. There's all sorts of pregnant 9, 10, 11-year-olds out there at all time. I order a urine pregnancy test so ubiquitously that I order it on patients that don't have a uterus all the time. Just because I just like, when I type in UA and they're female, it's finished with urine pregnancy. It's just like, yeah, exactly. In radiology, it was like, do you want it, or lab, like, do you want a UA? This pregnancy has a hysterectomy, and no. But it's just like, it needs to be, because I promise you, the one time you don't do it, you can get screwed. And I'll tell you about a story about how a partner of mine screwed me big time.
Wouldn't you do it anyways, because I assume we're gonna do X-ray or radiology because of she's a reproductive age?
Sure. Anything else? So right now we're at a urine pregnancy.
UA.
A UA, okay.
CBC.
CBC, why? What are you looking for?
With the dip, if there's any type of infection, put a UA would show.
Okay,
I don't know.
sure. So we'll do CBC.
Differential, so. Yeah.
What about a SED rate? Well, they have inflammation. I would have
Okay, anything else? Okay. So anything, we really can't rule in or rule out anything because we did it all at once after our presentation here. Okay, so you guys said fracture and disc, but yet we haven't ordered any test and or displayed anything on our exam or diagnosis that will rule in or rule out any of these things. So why are they on there? You're gonna do a
No, I thought we were
fracture.
going to radiology.
Oh, I'm sorry. Okay, yeah, sorry. Let's next. What everybody is will go.
X-ray.
X-ray. Okay, what kind of X-ray? Lumbar spine.
The one with the doesn't it pain start?
3.
L5 this one.
Not L spine, thoracic spine too.
Anything else?
Here we do thoracic.
Pelvis?
Thoracic spine, I want to do
Sure.
that.
All that.
Would that include the pelvis?
The
The
thoracic
lumbar?
spine X-ray?
The
include
lumbar.
pelvis?
The lumbar.
No,
Okay, so
just the
maybe
spine.
pelvis.
It tones it down into the spine.
So if you want pelvic.
I want
You
one.
want
Because
pelvis?
that's, we have the SI.
Yeah.
I don't-
You want to order some pelvic X-rays?
What's it called?
What are you looking for on that pelvic X-ray?
I don't know if the lumbar would also include the SI joint
It
fully.
doesn't.
So that's what, would that not be
What are
part
you
of the
looking
pelvis?
for specifically on the SI joint for your X-ray?
Like malalignment or something?
Okay. I don't know, hard to have malalignment of an SI joint, I would think.
I don't know.
Okay, bone spurs. Okay, okay. I mean, it's not totally crazy. I particularly wouldn't do it, but that's fine.
If they're chasing the zebra,
Sure.
you might have
Yeah.
your SI joints confused.
Yeah.
Yeah?
That's if you're running it.
Yeah.
Don't we even look at this?
Okay,
I don't understand.
we're zebra chasing healthy people with low back pain, and we're gonna be here all night. Okay. Okay, so the results of the UAs, are we good with that? Okay, so 2+ Luke esterase. She had TNTC, which is too numerous to count white blood cells. No RBCs. Her urine ACG was negative. She had 2+ bacteria, no epithelial cells. Her CBC was normal. And her X-ray of her T-spine, L-spine, and pelvis were all normal.
That's good news.
Okay, so what does she have? Cystitis, urinary tract infection. Does she have pyelo? I don't think so. I mean, she has back pain, but she's not afebrile, she's not vomiting, she doesn't have a fever, she's not tachycardic. Her white blood cell count was negative. Remember, that's not diagnostic, but that's a piece of the puzzle. Okay, so treatment. What do we want to do? Macrobid what? Dose. Oh. Asking me for a dose? Bizarre. Oh, what dose would you like, man?
Sufficient quantity?
Yeah.
You could. So, some sufficient quantity of macrobid that would alleviate her urinary tract infection. Mr. Pharmacist, please decide for me. Okay. Let's say 100 milligrams BID for 7 days. Does that sound about good? Sure. Okay. All right. Okay. You guys got the hint on these things? Now let's turn it
UTI
up.
wasn't on your differential.
Yeah, oh yeah, sorry, I erased this for you. Yeah, urinary tract infection wasn't on your differential.
PID would be another one.
Sure. All right. These are progressively going to get a little bit more difficult. First two are just kind of a warm-up. All right, now we have a 22-year-old male presents with multiple episodes of nausea and vomiting over the past 8 to 12 hours, unable to keep any foods or liquids down. He's feeling weak, dizzy, and lightheaded. He denies any fever, chills, cough, chest pain, or shortness of breath. He is having some mild abdominal cramping with vomiting. He has no significant past medical history. His vital signs are as shows: tachycardic rates 125, blood pressure 115/67, respiratory rates 28. His SpO2 is 98% on room air. Constitutionally, you see a mildly distressed young male. He has mild abdominal tenderness with no focality, no peritoneal signs. He is tachypnic, but in no distress, and he is tachycardic. No other significant exam findings. Mucous membranes are a little dry. Okay, what do we got? Differential. Gastro, okay. Say it again.
Drug toxicity?
Drugs.
Like kind of PCA?
Okay. I didn't include in there. He's not taking any medications. No medications. Denies any alcohol or drug or tobacco use. I should put the social history. I'm sorry, I'll add that. Oh, we'll still put drugs in there. I mean, people take drugs all the time and say they don't.
Yeah.
I had a guy who had alcohol level of like 300. Tried to tell me the other day he wasn't drunk. I was like, okay, sure.
Maybe not.
Yeah.
This is your normal baseline.
All right. What else? We got gastro and we got drugs.
Dehydration.
No. So if it doesn't say it in there, he doesn't have it. And if you specifically want to ask me something that isn't even close to in there, but maybe is kind of hinted a little bit, you can ask me. But if it's not in there, there's no trauma, there's no head injury, he didn't do any drugs, you have everything that you need that I got.
Dehydration.
Dehydration, okay? No. Food poisoning, we'll leave that with gastro. Flu? No fever, but okay. I didn't even put fever
I
on
was
there.
gonna say, you don't have
He has no fever. He's afebrile. Excuse me.
Bowel-
Pancreatitis. Okay, we'll put that over here. He seems pretty sick. you can die from pancreatitis.
Bowel obstruction?
Bowel obstruction, okay. Coli,
I said it loudly back then.
Appendicitis.
Abby, anything else? Okay, what labs do we want to do?
Pancreatitis?
Okay,
Okay.
CBC, CMP, lipase,
Flu swab?
flu swab,
Should you
a
do
UA, sure, absolutely.
Blood
Can you guys get urinary tract infections? Absolutely.
blood
It's
culture?
unusual, but it can happen. It'd be very highly unusual for a 22-year-old male to have a urinary tract infection, unless he's doing something with his penis that he probably shouldn't be doing. But it definitely could happen.
Blood cultures?
Blood cultures, okay. Why is that?
In case
Are
he
they
has,
gonna be bad for us?
they
No,
can help.
but gonna be helpful for somebody who's tachycardic and looking sick, and maybe they're septic. Oh, we wanna put that on here. Anything else? So we got CBC, CMV, lipase, flu, UA, and blood cultures. We good? Any radiological? So
Abdominal.
just do blood first, and then let's start working into special tests or radiological exams. Okay, do we want to do any treatments? So no rad,
No, I want an X-ray. There's a perf.
ultrasound, right upper quadrant,
Or the
okay.
bowel
Is there a
obstruction?
grant?
We'd
Yeah.
probably,
Abdominal X-ray?
Okay, treatment, you want to do
Will that show
fluids?
perforation?
What,
maybe,
normal saline, just say a liter?
I don't know.
Okay, Zofran,
yeah.
Okay, well, then again, we can't keep
you could do Phenergan, can't give, usually don't give Phenergan IV in most institutions. You can do a IM or the gel. I mean, not a wrong answer. I think Zofran, I would use Zofran more. Phenergan has more side effects than Zofran does.
Would you do an EKG first before you?
what?
Would you do an EKG before you? Is
Do
it,
you want to do an EKG?
I don't, is Zofran the one that prolongs the QT interval? I don't know.
Okay,
Yeah.
this is your deal, man. Okay, 1 liter normal saline, Zofran. Anything else?
He's not eating.
We should-
Okay,
Yeah, wait, he's
Is
dehydrated.
Brenner's appropriate here, since he's not eating?
good.
He needs something.
A what? KUB? Lab and radiologically this dude up.
I think that was good.
Okay, why KUB?
That's what you order for an abdominal X-ray.
Okay, why order an abdominal x-ray, not a CAT scan?
Money, like you don't, I mean, it's just a check, he has gastroenteritis, you don't wanna do a freaking CT scan and charge him all this money.
Sure, but what could he have?
Bowel obstruction?
Okay, would a KUB show either of these two? Or this? No.
So just.
They're on our differential.
CT, get all of that.
Could show small bowel. 22-year-old, no surgical history, normal healthy guy, probably not a small bowel, but could have it. Okay? If I was going to order, I rarely order KUBs. I think abdominal imaging is close to useless unless you're looking for constipation or, you know, constipation. In children, you can see, you can definitely see bowel obstructions. But you get an abdominal x-ray, see a small bowel obstruction, see air fluid level, dilate intestine, next thing you're gonna do is order a CT. So I skip that step. I think there's not a lot of diagnostic data that you can get from a KUB that you're not gonna get better, more accurate data from a CAT scan. And if there's no contraindication to it, and they haven't been scanned 10 billion times, I would just do a CAT scan. But anyways, we're getting off the point, we're getting run on time, so, but we can still do that. Okay. All right, here we go, we got, that's 17, sorry.
Is that before or after flu?
This is before. That is 91, sorry. 91. His hepatic function was normal, his lipase was normal. His flu was negative, his blood cultures are pending, and his UA shows 3+ ketones and 3+ glucose. Okay, so what are we thinking? DKA, okay. Is that on here? It's all right, it wasn't on mine either, that's a tough one. Okay.
He didn't tell us he was diabetic, is not. We might not know he's
might not
diabetic.
know.
He didn't know he's diabetic.
That's why we didn't think of it.
Okay, anything else we want to order? We want to reorder any labs and we want to do any different treatments. Let's do labs first. If we want to order any different labs. ABG, okay.
A1C and lipids.
Sure, you can add the BBG onto it. See, okay. A1C and C-peptide is going to help us zero. This patient, so reevaluation of this patient, his heart rate is now 130, his blood pressure is 90/60, and his respiratory rate is still 30. Okay. Okay. So ABG and A1C, do we want to order anything else?
We need to know more.
Okay. Let's go ahead and throw a serum ketones on there. Okay. We do have positive urine ketones, which is enough to get us DKA, but we still want those serum ketones to be more accurate. And a lot of times, UAs test for a certain type of ketones. It's some kind of acetate form of the ketones, and that's the least common produced ketones in diabetic ketoacidosis. The beta-hydroxy ketones are the most common, so you want to try to get the blood one. So you can have people in DKA that may not have a big a finding on serum ketones because it tests for a certain one that's not as common in DKA. But we don't have serum ketones in our hospital, so we have to rely on what we have here.
Would you like absolutely need an ABG since you know his bicarb's low, so he's in some kind of acid?
You know he's in some kind of acid base, but there'd be a difference in disposition for somebody who has a pH of 7.1 versus 6.7, right? Don't know that based on this. We know he has some kind of acid-base disorder and likely some metabolic acidosis, but we don't have a firm pH. I mean, you're talking to a critical care doctor or a hospitalist, he's going to ask, what's his pH? Bicarb's 10. Okay, and now treatment. So we want to do anything else for treatment?
Insulin.
Insulin, how much insulin?
Bicarb?
How much insulin?
10 units.
10 units? So do
Regular.
you want to do an insulin drip or do you want to do a bolus?
I would do a
Drip.
Maybe
Wait,
a bolus.
doesn't show the bolus and
He's 780, do it.
Okay. So 10 unit bolus and then maybe a drip after that?
Yeah.
What drip do you want to do? Okay, what rate?
10 units per hour.
Okay,
Drop it 100 per hour, right?
do what?
100 per hour, 100 per hour.
Okay.
I don't know what
He weighs 70 kilos. He weighs 70 kilos. Let's typically do 0.1 units per kilogram per hour. That's your standard, so that's going to be about 7 units an hour for him. Anything else? We've given him 1 liter of normal saline.
Bicarb? Would you give him any bicarb?
Another liter. So we'll make this 2. Bicarb.
Would you give him bicarb if you,
I would not give him bicarb,
okay.
but tell me why.
For the deficit that he has, possibly?
Okay, why are we not giving bicarb?
Why not?
Yes.
Because when it adjusts it too much with the insulin, like they'll flip it the other way too quickly.
Okay, it's a long pathophysiology answer, we'll discuss it after we're done right here.
Okay.
But there is a reason why we don't give bicarb to patients in DKA. Even with people with bicarb of like 3 or 4, there is a reason that, and
Okay.
we'll talk about it here in a second. Don't let me forget that.
Okay.
Okay, so we'll give another liter of normal saline, give him 10 units IV insulin bolus, and we're starting at 10 units, and we're starting 0.17 units an hour, correct? Okay. After that, your patient, your vital signs are now, he has no pulse, he has no blood pressure, his EKG shows a ventricular tachycardia, and he's, technically dead, but we may want to get him back. Shock him, whatever, we shock him a couple times, give epi, blah, blah, blah. Sure, we did everything, he died. So we officially killed this patient.
Oh, we didn't give him that.
Don't feel bad, everybody, every night I lecture, no one's ever not killed a patient before. What mistake did we make?
We didn't get a finger stick,
We've got the blood glucose here, it's not gonna be different.
found it.
Thiamine or something? Wait,
No, not alcohol, not thiamine.
No, there's something that you get from
What is his mannitol?
Too fast?
Is that it?
What did we flip too fast?
So we dropped his.
His blood sugar.
Dropped his blood glucose, are you gonna, okay, so how much will 1 unit of insulin in a normal patient drop their blood sugar? 35 to 50. And so he's likely a type 1 diabetic given his, so he probably has some decreased insulin production. So his cells are going to be sensitized to insulin appropriately, correct? They're not type 2, they're not going to be desensitized. So they're going to be highly sensitive to insulin. So we gave him 10, and we'll just say 35. So we just dropped it down 350, which is about half. Not a big deal. Is that why he died? No.
Encephalopathy.
No, so that would be a cause of that, but that's not why he died. You don't go into ventricular tachycardia because of cerebral edema.
Electrolyte imbalance.
Okay, what? What electrolyte?
Potassium.
There we go. So what does potassium do, or what does insulin do to potassium? Pushes it in the cell, drives your extracellular potassium down. So you just took a 2.8 into 0.6, and then now he's in VTAC and died. What is going to fix this guy's problem? Fluids. Correcting the osmolality, the osmotic problem with too much, too many ketones, those anionic bodies, and the osmolar gradient differential that you have with that. Isotonic fluids is what's going to help this guy. It's going to help his acid-base status, and it's going to help his fluid volume deficit because he's completely dry. That's the pathophysiology of DKA. You're losing fluids through urine, vomiting, everything like that. It has nothing to do with the glucose.
We gave him normal.
Sure. You don't give IV insulin if they are at 3.5 or less. It's just fluids. And from 3.5 to 6, you do 10 milliequivalents per hour or per liter of fluid given of potassium when they're 3.5 to 6. If they're 6 or greater, then obviously you're not giving any potassium, right? Got to look at that. Insulin is a dangerous drug, but it's so ubiquitous and everybody gives it, and it's just like 10 units of IV insulin bolus, just right off the tongue. It flowed off everybody's tongue here so easily. That is a dangerous drug, man. And you got to know some stuff before that.
So would you have just given like 4 liters of fluids of what normal saline, or would you have?
I would have given
I said,
2 liters normal setting or lactated Ringer's. I'm starting to like lactated Ringer's more than I am normal setting. You get a little bit more electrolytes in there and doesn't, contrary to what it says, lactate is not going to elevate your lactic acid in somebody who has normal kidneys that are processing lactic acid. And then, yeah, I would give him like 40 units of IV potassium over 4 hours until I got that up. And then once it started to slowly climb, I would put him on a drip before I gave him a bolus. You can still give him a little bit of insulin. I'd probably give him like 3 units an hour or something like that as I'm continuously replacing his fluids and potassium. But big boluses of IV insulin are going away, man. I just listened to a lecture today over euglycemic DKA. So that's DKA. My partner had a case like this. I mean, exactly like this, except these were his figures. It was 1.5. And I didn't give you the anion gap, but this guy's anion gap was through the roof, and this other one was 40. So this guy had an anion gap of 40, a bicarb of 2, and a blood sugar of 195, and he was in DKA.
Wow.
That's a little bit headier. That's euglycemic DKA, which is tough to kind of wrap your head around. It is another lecture in itself. But recent literature coming out for insulin administration, people are going away from boluses and they're starting out at 0.14 units per kilogram per hour. Drip. Right off the bat, no bolus. Because this has less hypoglycemic effects and less alterations to your electrolytes than giving a big bolus. That glucose, no matter how high, 1,000, 1,000,000, whatever, is not going to be your big problem. It's the acid base, and it's the osmolality, it's the lack of fluids is what's going to kill this person. Pour fluids into them. That's the most important thing. Not insulin, not all our stuff, fluids. Cool? Make sense?
10 micrograms per liter per hour on that potassium, is that what the drip is up there on your
Yes.
potassium?
Yeah, so add, or not micrograms, milliequivalents. 10 milliequivalents per liter of fluid given. So if you're given 3 liters, then you're doing 30 milliequivalents, right? That's the kind of additive that you go. What's the maximum rate you can run potassium intravenously?
is this Vanessa's lecture?
Exactly. Look it up, and look it up again.
I feel like it's 9 something.
1 milliequivalent per kilogram an hour?
1 milliequivalent per kilogram per
That's
hour?
in units.
70 milliequivalents in 1 hour?
That's in units and piece, hold on.
Isn't this what Vanilla lecture was?
It can be. It was red herring, meant to distract you guys.
Oh,
So your typical rule of thumb is going to be 10 milliequivalents per hour, okay? And most times, most institutions are not going to put more than 40 milliequivalents in 1 liter of normal saline, so you're talking over 4 hours. 10 milliequivalents per hour is your typical go-to infusion rate for potassium. If you get somebody in there that has like a 1.2 and they're like ready about to code and die, you can give up to, I think it's 15 milliequivalents per hour. But you bolus somebody with potassium, you're gonna kill them. I mean, I think that's how you kill people legally in the jail system.
So you said you would do 40 over 4 hours for that guy?
Yeah.
Would you do that separate from his
Yes.
fluids going?
Yeah, I continuously bolus them with
So I was like,
fluid.
that's really
Your
too
fluids, in your first hour, don't you give like half of what you're trying to prep? I thought with DKA, and then you have like a specific, like, you give so much in the first hour, and then the next 2 hours you have like half of that.
For fluid administration? I don't know what you're talking about. I think something that's close to that is the Parkland formula for burns in fluid administration. That formula, you give half of what you're trying to give in the first hour, and then it's like 25% over 6 hours and stuff like that. something similar, but I don't know of any
No, no.
fluid rate requirement for that. Yes?
So during the code, if we had noticed the potassium, could there have been any fix for it at that time? Like, I don't guess.
During the code, so giving the epinephrine will cause a shift in potassium elevation and glucose and the whole bit, but not really. I mean, you can give, yeah, I mean, you can try to give some intravenous and a drip, but like I said, you can't bolus them even in code. It's gonna be, I mean, that's gonna be a tough guy to get back, because the reason why he's in ventricular tachycardia is because of his low potassium. So you can shock him back into rhythm, but it's just gonna go right back into VTach because of the cause of it, right? Okay. Good. We're taking a little bit too much time, but we're talking a lot and we're getting good. Bicarb. I like to use my little pointer to point at you. Bicarb hits chemoreceptors in the brain faster than it does in the body, so it creates a mismatch in what your brain thinks your pH is and what your body thinks your pH is. And so, why was that guy breathing 28 times a minute? He's trying to breathe off CO2 to elevate his pH, right?
Okay.
When you give a big bolus of, so that's a compensatory mechanism. We want that. We don't want that to stop. We want it to be 28. As long as he's still satting fine and breathing comfortably, that is the body's fastest way to change acid base, right? You got the kidneys are bolusing out a bunch of bicarb, which isn't doing any good because it's tin, because it's, you know, it's not conjugating the acids fast enough. And you got the lungs breathing a ton, blowing off CO2 so that you can get your, so you give bicarb,
The brain thinks.
brain thinks that the pH is fine, slows your respiratory rate down.
Okay.
And so you lose your body's own compensatory mechanism to help you maintain an adequate acid base status. And so we don't want that,
Okay.
right? Other causes, sepsis, and codes, cardiac arrest, where you have an abnormal accumulation of acids and you don't have enough bicarb production, then yeah, absolutely, we're given bicarb intravenously because that's helping in that aspect. For specifically for DKA, giving the bicarb is going to inhibit our own body's process to help correct that, so we don't want to give it.
Okay.
I've never given bicarb in DKA, and I've seen some pretty low pHs. I mean, not just because it's me, I've asked, like, critical care doctors and stuff like that, and they're like, no, just dump them out with fluids.
Okay.
Okay, so this will probably be, let's run through this one really quick because the case 6 is good too. Actually, we're going to skip this one because this is pretty simple. It's myocardial infarction, but there's a few points that I want to talk about MIs, right? And what you're going to get from this, this was kind of a sneaky way to do MIs. We'll just kind of go through it real quick. So this is a guy I personally had, and his chief complaint was chronic neck pain. He had neck pain. He had a history of chronic neck pain. He's had multiple surgeries on his neck. He takes like 60 oxy-IR, dude came off as like a total drug seeker, person that you can see all the time in the yard. The only caveat to this was he said one thing to me, and he said, yeah, my neck pain hurts and it feels like it's pulling right here into my chest. And that's all he said. He wasn't short of breath. He didn't have any frank chest pain. I said, are you having chest pain? He's like, no, it just feels like it's pulling right here. He was having a gigantic inferior STEMI. And we only figured that out because I ordered an EKG. Why did I order an EKG on somebody who was so very clearly talking about chronic neck pain? Because he pointed at his chest. It is a fast, it is a cheap, and it is a easily interpreted test that will help save your butt so many times. They come in with chest pain, get a freaking EKG. Anybody, 21-year-old kid comes in with chest pain, get an EKG. Takes 30 seconds, you look at it, normal sinus rhythm, done. You know what I mean? You'll catch, I had a 34-year-old guy, had an in-STEMI that ended up having to get a 5-vessel bypass. 34 years old. Get an EKG, man. Yeah, it's ridiculous. So, get an EKG if they have chest pain, first point. Get inferior EKG if they have ST elevation in the inferior leads, you're looking for right ventricular problems. You load them up with nitroglycerin, you're going to bottle the blood pressure. I talked to you guys about that in cardiology, right? Get an inferior EKG. And the other one that this is like my own personal vendetta against whoever came up with this. And this may be a little controversial. This may be something that goes against what you are even being currently taught. Take that with the caveat that I, by no means, say I'm the smartest person in the world. But MONA, have you guys all heard of that? All right, forget it. MONA is dead. MONA is a dead acronym. Don't do it. And I'll tell you why. Crusade Initiative. 2007 trial said giving morphine caused an increase in morbidity and mortality, patients suffering in STEMI by 27%. Don't give morphine. American College of Emergency Physicians just came out with a physician paper saying oxygen in oxic patients has no benefit. Now they didn't say that it was bad for them, but there's no benefit. If you have a normal oxygen saturation, zero benefit for oxygen during a myocardial infarction. Now there is some literature saying about, free radical production and over-oxygenation can inhibit cellular tissue regeneration and worsen the effects of that, but that's a little bit iffy. But they just came out with a paper talking about oxygen. Okay, and I already put my scratch through the end. A paper in Australia just came out talking about nitro, showing that it had no benefit in myocardial infarction. Now, it helped with pain reduction, in symptom control, absolutely. It helped patients feel better, their chest pain resolved, it improved. And I'll send you guys links to all these papers so you just know I'm not making that shit up. But nitro is starting to lose favor. Now, do I still give patients nitro? Yeah, I still do, because there's not a paper like these two that say there's no point. There is, what I'm trying to go to is that there is increasing literature saying nitro is not even a big deal. Aspirin, dear God, give it to them. So now the new acronym should just be NA, or A. Hey, like Ponzi thing. So yeah, give them aspirin. That's a CMC core measure. If you don't give aspirin to somebody who's having a heart attack, your hospital's going to lose a bunch of money, you're going to look like an idiot. Give them aspirin, there's all sorts of stuff to it. Nitro, I'm a little bit iffier on. Nitro can get you sometimes going down a weird path. One, if they have symptom reduction with nitro, oh, it has to be cardiac. No, absolutely not true. Just because they have resolution of chest pain with nitro doesn't mean that it's cardiac in nature. Kind of points more towards it, but not a diagnostic indicator. And just because they don't have any resolution with nitro and chest pain doesn't mean that it's not cardiac. You know what I mean? Well, they didn't do anything with nitro, this must be a GI thing, let's try a GI cocktail. No. So, morphine, oxygen, for sure out. Those are done. Nitro is starting to get a little iffy about it, but there's not a lot of great big studies on it. Aspirin's always been in and will always be in, that's a great thing.
What if they're allergic?
Right, yeah, exactly. Yeah, 325, I mean, people routinely take 650 of aspirin all the time, so it's like no big deal. And then nitro, yeah, for the inferior wall MIs that have more right ventricular preload, dependent for blood pressure, you give them a bunch of nitro, you're going to tank their pressure. Okay, last one, I promise. We do one more? You guys cool with that? Can we do that?
Oh, yeah.
Okay. You guys cool with everything I just said?
Yeah.
How many times have you heard Mona here?
Actually,
I didn't even know what it was.
Some of our professors are going more into it.
Good,
I'm
good.
pretty sure they told us morphine no from the.
Yeah.
Okay, good.
I think it was our first.
There's a few things I come up and say, and it's still like dogma, it's still taught. I hate, I don't want to step on anybody's toes, but absolutely, morphine and oxygen. If they're hypoxic, give it to them, sure. But if they're normal oxygen, then you don't need it.
Do you replace morphine with anything?
Dilaudid, fentanyl. Yeah, I still give them pain medicine, just not morphine.
What do you give them with an aspirin allergy? Do you just override that, or
You just don't give it, or you can do a PGY12 inhibitor like clopidogrel. But you want to be iffy on clopidogrel because if they're needing emergent bypass grafting, that'll inhibit them. You have to do a PGY12 washout.
What about heparin, because you can
Yeah,
reverse it
stop
with
it.
heparin.
Plavix and Effient.
But like, with like an aspirin, you want them to chew it up